Okay, everybody, let's get started. Welcome. Look at us all here together. How many people are here today, and this is the first time you've been in a big group of people and seeing people you haven't seen for a long time? Yeah, pretty special. So welcome, welcome, welcome. The primary goal of today is connecting with each other. It's getting together, it's meeting each other, it's seeing each other from above, or I guess below, the shoulders, right, after all the Zoom. And making connections with each other and learning about each other's programs and our work. It's about sharing our knowledge and experiences. So yes, I'm Rebecca Penn. I'm the project manager. I work for London InterCommunity Health Centre, project manager for the National Safer Supply Community Practice. And most of you know all about the community practice, but for those of you who may be new, we are funded by Health Canada's Substance Use and Addictions Program. We're a knowledge exchange and capacity building initiative, and we're tasked with this, supporting the scale up of safer supply programs across Canada. The focus is on a medicalized model. However, we all know that there is a very high need of a lot of different models, non-medical models, and we're very supportive of those conversations and the work that's being done in those directions as well. We are also a collaborative. The program operates by London InterCommunity Health Centre, Alliance for Healthier Communities, and the Canadian Association of People Who Use Drugs. And we have people from all three organizations here from our leadership, as well as other members of other programs and such from those organizations. But the big group of people who makes this work happen are you and our 850 other members. And what's amazing about our membership is just how widely diverse it is. We have very diverse identities, roles, very interdisciplinary, and also from across Canada, so that's really exciting. So let's get started. I want to start off with, what did I do? There we go. So, yeah, I'm really excited to be here with you all and share this space with you. And I'd like to thank you all for coming here from across Ontario. We have people from all over Ontario here. And I want to just take a moment to acknowledge this land where we are gathering today. Today we're meeting on land that is part of the traditional and unceded territories of many Indigenous nations, including the Mississaugas of the New Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. This area is now home to many other First Nations, Inuit, and Métis people. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms comes from the history of colonialism and its enduring practices, institutions, and ways of thinking. Colonialism is with us today. It's part of our everyday lives. And as we work together today, we encourage you to share with others where you're coming from and to reflect on your relationship to these lands and how your role and work relate to and are affected by colonialism. So, today's program. I know people have been dying to find out, what are we actually doing here today? So, yes, we've got a great program for you today. We've got an amazing group of people here. In your welcome kit, hope you've already explored your welcome kit a bit. You'll see that there is a program in there, with information about all the presenters and people that are here with us today. You'll see that we have some amazing people who've worked really, really hard to make today happen, often on some short notice. And isn't this what the field is like? We rally around and make things happen, and I'm really, really grateful to each and every person who's made today possible, leading up to and leading to the day happening all day. We have a great group of, in addition to our team, the National Safer Supply Community Practice team, who I'd love to give a little shout out to because they've been incredible. I'm just really thrilled with my colleagues. We also have a group of people who have come together to be the community safety and conference support team. You'll notice we're all wearing our Safer Supply t-shirts. If you need anything, please do let us know. We're here to help and make this day as good as possible for you. And my sincere thanks to each of them. Okay, so some housekeeping. Safety and community care. So we really do want to make this a safe, welcoming, happy space for people to be. We want this to be an experience where people do feel it's a safe space. And so the mask mandates are changing, and everybody has different levels of comfort. And so I invite you to be aware of what other people's comfort zones are if you're in close proximity to them. And yeah, we'll all take care of each other. So thank you. We do have a health room. The health room is kind of hidden by the column, but when you first come in, it's just to the right. If you come out the door, turn immediately right, it's right there. In there we have some trained staff. Princess and Alex are there, and we're really grateful for them. They work at the CTS at Parkdale Queen West, and they're there to help provide support, supplies, and other things for people. So if anything's needed, please go in there. Our community safety team is also available to go for walks with people or take time with people or do whatever's needed. So please feel free to reach out to us. In terms of accessibility and support, if there's anything that we can do to help make this event more accessible for people, please let us know, both what we can do immediately and what we need to think about in the future. The bathroom here is not very wheelchair friendly. There is another one that is more wheelchair friendly in terms of it has a stall for wheelchairs, and it's just further down the hall. But if you need help opening doors or anything like that, please, we're all out and about, so just give a wave. We're recording this event, and we will be posting it on our website. That will include questions and things like that from people, so just keep that in mind. What else? Food and drinks, we're gonna have a break, 2 breaks today, and lunch, and that's all gonna be out here. And we have gender-neutral washrooms just outside and to the right here. Parking, if anybody's parking, you can go to the registration desk. They'll give you a little card, and you'll get a discount on your parking. Okay, let's get started. So, you've already had me. We'll have a message from the Honourable Carolyn Bennett, Minister of Mental Health and Addictions, and then I'm going to pass it over to Dr. Andrea Sereda. Thank you. We're just figuring out the message, sorry.
I'm Carolyn Bennett, the Minister of Mental Health and Addictions and Associate Minister of Health. And it's my pleasure to be able to speak with you today from the traditional unceded territory of the Algonquin Anishinaabe people. I'd just like to begin by thanking the National Safer Supply Community of Practice for organizing this event, but also for your ongoing dedication creating a community of safe supply from across the country to connect and learn from one another about the initiatives and progress in providing a regulated supply of drugs in response to the toxic drug crisis. Créer des liens et retirer un savoir de personnes comme vous sont des éléments essentiels de mon travail. Je me réjouis vraiment du fait que l'événement d'aujourd'hui servira de lieu où accroître la collaboration, l'expression d'idées et l'engagement. We all know the importance of your efforts to build the evidence base and share knowledge in order to help scale up successful, safer supply models. In March, the Prime Minister was able to meet Dr. Nanki Ray at Parkdale with many of you, like Dr. Tu at Kalela Lalem in Vancouver online, to learn about your life-saving work and advocacy for bold changes and better significant policy change. In April, we visited Dr. Andrea Sereda at the London InterCommunity Health Centre to learn more about the amazing work being done through Safer Supply initiatives in Ontario. As you all know, early findings show that initiatives like the one in London can help prevent overdose, save lives, and connect people who use substances to other health and social services. This has never been more important as the overdose crisis continues to take such a tragic toll on communities across the country. We also met with Dr. Sutherland in Vancouver to learn about her project working with people using drugs to provide powdered fentanyl capsules with a compounding pharmacy. We are committed to help you bring Canadians on side as, with your help, we take the bold actions and significant policy changes called for by the expert task force last year. Vous savez ceci mieux que quiconque. De plus, vous avez le courage, la sagesse et l'expérience nécessaires pour mettre de l'avant des solutions face à la crise de surdose. C'est la raison pour laquelle nous faisons appel à votre expertise au moment où nous élaborons des politiques et des programmes qui répondront davantage aux besoins des personnes qui consomment des substances. Diriger une approche pansociale pour répondre aux risques liés à la consommation de substances est synonyme de travailler ensemble et tant que partenaires. C'est-à-dire nous tous, les gouvernements fédéraux, provinciaux et territoriaux, les administrations municipales, les communautés autochtones, les personnes avec une expérience vécue et vivante, les communautés de soins de santé et les organisations offrant des services sociaux. Le gouvernement du Canada est fier d'appuyer la communauté de pratique nationale sur l'approvisionnement plus sécuritaire. Financé par le programme sur l'usage et les dépendances aux substances de Santé Canada, et de contribuer à la mise en œuvre d'événements comme celui-ci. Cette crise dépasse chacun et chacune d'entre nous, mais ensemble, nous avons ce qu'il faut pour sauver des vies. Reducing stigma is a key part of the challenge, as you know. This is especially relevant in the safer supply space. We know that stigma prevents people who use substances from reaching out for help, making it less likely that help will be there when it's needed. Stigma also perpetuates misconceptions that substance use disorder is a choice, which can cause some healthcare providers to become reluctant to care for people who use substances, which in turn makes substance users distrustful of medical providers. Today and together, we can break this deadly cycle. People using alone, people dying alone. Together, we can effectively address the deaths resulting from the toxic drug supply. Now, as you know, last week I granted British Columbia's request for an exemption under subsection 56(1) of the Controlled Drugs and Substances Act as one of the province's comprehensive responses to address the overdose crisis. This exemption means that from January 31st, 2023 to January 31st, 2026, adults in British Columbia will no longer be subject to criminal charges for possessing up to 2.5 grams of certain illegal drugs for personal use. The Government of Canada will collaborate with the province of BC to carefully implement this exemption and ensure rigorous ongoing monitoring and evaluation. By supporting British Columbia with this life-saving approach, we are also treating substance use as a health issue, not as a criminal one. However, this exemption is just one tool we are providing to British Columbia to help them address substance use harms and overdose in its jurisdiction. Their implementation plan includes diversion from criminal justice system to increased health and social services, ongoing consultations with all stakeholders, public education, law enforcement training, and the development of a robust dashboard of data that will monitor in real time the public health and public safety indicators. We will continue to measure adapt and measure again. We will be prepared to change the application in order to make sure we're meeting the public health interests. It is clear that in order to save lives and connect more people to the service they desperately need, we must move forward on this work together, which is why I look forward to hearing more about your discussions and recommendations from today's meeting. Our government will continue to consider all options and more innovative solutions to the overdose crisis and other substance-related harms across the country. Our work with experts such as yourselves will continue to inform our next steps on these important matters. Once again, thank you so much for everything you do. Your ongoing work in the safer supply space is making a difference. I look forward to our continued work together. Thank you. Merci. Miigwech.
All right, now it is my sincere pleasure to introduce and welcome Dr. Andrea Sereda from London InterCommunity Health Centre. Andrea, I'm going to let you take it from here, and you probably don't need more of an introduction than that, but feel free to continue. Thank you.
Thanks, Rebecca. So I'm Dr. Andrea Sereda. I work as a physician at the London InterCommunity Health Centre just down the highway in London, Ontario. And we're thrilled to be a big part of organizing today with the National Safer Supply Community of Practice. So I remember exactly the moment 7 years ago that I decided to write my first prescription. Better? Early in my career, I had cared for this beautiful, vibrant woman, and I'm going to call her Tanya, just so that I have a name to use in this story. And Tanya was full of this crazy life. She would tell me everything she thought about the world and what she was going to do with her life in it. And she would bring her puppy to all of her appointments because she knew how much I loved dogs and that I had 4 dogs at home. She would drop off little presents like flowers and feathers for everyone at the clinic, and she was really good at filling her life with joy where she could find it. And she was also living unhoused, and she was also injecting unregulated drugs. So, as often happens, unfortunately, in my practice, I lost touch with Tanya for a little while. So we fast forward 3 or 4 years into the future, and I was working, and a nurse asked me to come over and assess a woman who was having some trouble breathing. And this woman, she was puffy all over because her body was edematous from heart failure. Her face and her legs and her belly were huge and swollen, and she could barely walk. And this woman was dying of HIV. I talked to this woman and I examined her. I had absolutely no idea that this woman was Tanya until I ordered her chart to order some blood work. Tanya and I talked about how she had been injecting hydromorph contin and fentanyl since we last knew each other. We talked about the horrible endocarditis that had completely destroyed her heart. We talked about her puppy, who was now grown up but was still always at her side and in fact was in clinic with her that day. Tanya died 2 nights later of a cardiac arrest. The notes from the emergency room, I'm going to describe her case, show that they actually barely tried to resuscitate her. She was just an addict. My mind screamed at me after Tanya died. It screamed, "This is fucked up. This is fucked up." I think I cried for a week. And then another woman came in. This woman had just recovered from her first bout of endocarditis. She had been discharged from the hospital a couple of days ago with a weaning script for dilaudid tablets. She was injecting those tablets, and she was doing okay. And I thought to myself, am I going to let her die too? And I took this huge, terrified breath, and I prescribed her dilaudid. I spent probably the next 4 years being terrified, and my team sitting over here, they manage me, they help me with my anxiety and panic, and they held my hand through all those early years, and I can't thank them enough. But it was terrifying. I was afraid of more people dying. I was afraid of not being able to do anything about it. I was afraid people would find out what I was prescribing and how people were using it, and I would lose my license or get arrested. I was afraid that maybe I was doing the wrong thing and I was actually hurting people. And some of those fears came true. people did find out that I was prescribing Dilaudid so that people could inject it. Prominent addiction medicine physicians like Dr. Malkahan and Dr. Sharon Koivu, they took me to the College of Physicians and they tried to shut down what we were doing in London. Those same prominent doctors said publicly that I was killing people. And the fear of death, it kept going too. For every life that was saved on Safe Supply, we seemed to lose another 5 people. But slowly, through those years, that fear started to be balanced with hope and determination. Our team in London, we started building the evidence that we were saving lives with Safe Supply. In year 3, we started actually talking about what we were doing publicly at conferences and in the media. I met people like Dr. Gillian Kolla and Zoe Dodd and Karen Ward and Guy Felicella. I met Garth Mullins and I completely made an asshole out of myself fangirling to him at a conference in Portugal. So meeting all of those people, Gillian was there, she's laughing at me. I learned that what we were doing in London already had a name and it was called Safe Supply. Year 3 was a watershed for opening up the conversation on Safe Supply. We presented our results at conferences across Canada, and we met people who used drugs from across the country, and we learned everything they had been facing for years. I was humbled by what I learned from drug users about prohibition, the death of their communities, and the way they had been treated by the medical system and the passion with which they were fighting back. Year 3, that was also the year that those addiction medicine docs took us to the college and tried to shut down Safe Supply in Ontario. They were unsuccessful, and they taught us a lot about what doctors are willing to do to defend the status quo in addiction medicine. In year 4, Health Canada looked at our results in London and they gave the health centre $7 million to expand and study Safe Supply. And we started the really hard work of bringing our program up to meet the needs of 300 humans. In year 5, Health Canada gave almost $30 million to support pilot Safe Supply programs across the country, and I know a lot of you are here today. And we started to work on the national community of practice as well. The grassroots network of people who are fighting back against this poisoning crisis, it grew and we connected with each other. In year 6, Safe Supply was a topic in the 2021 federal election. In year 6, the UCP in Alberta felt so threatened by the growing Safe Supply movement that they commissioned a report to make us all the boogeymen bringers of death. And now it's year 7, and we are here together in this room. We have accomplished so much together. Can you please give yourself a round of applause? When I went to med school, I was taught that knowledge was built with tiny building blocks. Every generation of doctors, we added our own little bricks and built on the experience and research of the generation before us. I was taught that medicine was supposed to be this carefully constructed foundation, and again, brick by careful brick, we were supposed to be building a structure to house our patients within. Then I started this work, and my doubts started seeping in like drips of water on that foundation. What if the foundation that medicine was built on was rotten? What if medicine wasn't actually built to support everyone? What if that meticulously built foundation didn't actually support the health of all people? And what if instead it was built to protect only some of us? What if the wall was actually built intentionally to exclude some people? Medicalized Safe Supply, which is what we're going to be talking about today, is tearing down those presumptions that medicine has built about drugs and the people who use them. Medicalized Safe Supply is building the evidence to show that, yeah, unregulated drugs are what are killing people, but those drugs are only the final common pathway, the final common bullet. Medicalized Safe Supply is showing that all of the lifetime harm that comes to people who use drugs before that final bullet of overdose is actually what is harming and killing people, and it's not actually about the drugs. It's not about the drugs. It's about how we treat the people who use them. It's about how people who are excluded, it's about people who push so far into the margins that we don't, as a society, have to bother to care that they are mourning 25,000 dead and counting. To the clinicians and allied health workers in this room, you're here because you want to help. But helping means so much more than writing a prescription. Helping means putting your power and privilege in the line of fire for others who don't have that. Helping means doing things that make you scared because they are the right thing to do. Helping means deconstructing almost everything you were taught. To the politicians and administrators and funders in the room, you can have good polls or you can save lives. You might not be able to do both. You might not get reelected, or your bosses might not get reelected if you bravely push equity and justice for drug users. But there's many faces in this room who could die if you do not do the right thing. To the drug users in the room, Safe Supply has changed me because I met you. I am very grateful that you allowed me to know you. You have my gratitude and my devotion and my trust, and where you lead, I will follow. Thank you, stay safe, and keep six.
Thanks so much, Andrea. That was amazing. Yeah. So now I'm going to invite our panel for our first session to come on up, and we'll get set up and we'll get going. Where's Nancy? There's Nancy. And everybody's slides are over there, I think. So there is a clicker here. Perfect. Just really exciting. All right. I'm going to introduce all of you. Yes. And I'm going to start off by introducing you. Okay, so our first session today, I'm really excited about, is on evidence and the research happening around safer supply. I'm going to introduce Nancy Henderson, who will take it from here. Thank you, Nancy. Thank you, panel.
Hi, everyone. Thank you. I am going to introduce our first panel that we have here today. First is Dr. Gillian Kolla. She's a postdoctoral researcher at the Canadian Institute for Substance Use Research at the University of Victoria. Next, we have Dr. Carol Strike, who is a professor at the Dalla School of Public Health and a harm reduction researcher for over 25 years. And then last, we have Dr. Adrian Guta, who is an associate professor in the School of Social Work at the University of Windsor. Thank you.
Good morning, everyone. So I'm going to take you on a pretty rapid fire tour right now of some of the evidence that has already been published around safer supply and some of the evidence that is forthcoming in the next little bit. And then Carol and Adrian after me are going to be talking specifically about some of their results from doing interviews and research with Ontario's safer supply programs. But just to get us started, I think it's really, really important to situate why we're all here and where safer supply came from in the first place. And Andrea did a pretty good job of that already. But I just want to have a moment to hold space for all of the people who aren't here with us today, because we have lost so many of our friends, our family, and our community members, not just in the last 5 years, 6 years, but especially in the last 5 or 6 years. And it chokes me up every time that I have to get up here and talk about these numbers, because I know how much these numbers, the people behind them, what they represent for our communities, and all the loss and the grief and the trauma that this represents for our communities. And I just want to really keep us focused that behind all of these numbers, behind all of the evidence that we're sharing here today, there's real people who are suffering real harms at the hands of criminalization, colonialism, racism, systems that just do not care about the lives of people who use drugs. And I'm hoping that we're starting to seeing some progress there. We're starting to see some movement towards changing that and thinking about how we as communities can care for people who use drugs. But it's slow, and I have to admit that it's been really, really frustrating. And especially looking at these numbers, I turned to Carol when Carolyn Bennett was speaking, and I said, well, before this I was nervous, and now I'm just a little bit mad. It was 2019 that Ontario had the highest number of people in Canada who died that we took over from BC in that awful, awful title. And we've unfortunately only continued since then. We don't just need decriminalization and a comprehensive response to the drug toxicity poisoning crisis in BC. We need it in Ontario. We need criminalization here. And I also just want to hold space for a moment for the frustration that I know that people are feeling about how slow this has been going, this progress has been going. Incrementalism at this point feels like death by 1,000 cuts. So that's not the most inspiring place to start the morning, but I think we need to start there, unfortunately. And I think it's also important to acknowledge that the reason that we're in this mess is because the unregulated drug supply started shifting towards fentanyl and has continued to shift to fentanyl. That blue line that you see shooting up there starting at about 2016, 2017 is the proportion of deaths in Ontario where fentanyl was the direct cause of death. This has unfortunately just continued to the point at which 90% of all deaths in Ontario right now from opioid-related overdose are caused directly by fentanyl. And I think it's also important to state that the pharmaceutical opioids along the bottom that you see there, since COVID have started, are actually a smaller proportion of the deaths. Pharmaceutical and prescribed opioids are not what is driving this crisis. It has and always has been fentanyl. So, I'm going to shift for now. This is one of the first papers that we managed to publish in Ontario. We decided to take a look and see how many prescribers were prescribing safer supply in Ontario. And we looked at data from 2016 till March 2020. I think March 2020 is going to become a convenient cutoff point in the next little while when we're looking at a lot of health data because of how dramatically things shifted due to the COVID pandemic. We had actually planned to do this even before COVID, but I think it is actually just a very, very convenient point. And we looked at prescriber characteristics from the pharmaceutical databases that we have here in Ontario. What just happened? What did I do? Oh no, oh it's back. And what you can see is that there was a pretty slow but steady increase in the number of prescriptions for safer supply that we were seeing in Ontario, and that this took off in about the third quarter of 2019. We hypothesized in the paper that this is partly due to the fact that this was when, as Andrea started to mention in her talk, this was when people actually started talking about the fact that they were prescribing safer supply, and this is when, in Ontario, we published the guidelines around safer supply. Then it kind of leveled off in the fourth quarter of 2019. And I'm really interested to redo this work in the next little while to see what has changed since the pandemic. What we did was we cut the data in two ways. We looked at people who were infrequent prescribers, and this was people who'd prescribed 2 courses of less of safer supply. And then we looked at frequent prescribers, and we wanted to see if there was any differences in the way that they were prescribing. It turns out that 26 prescribers, or 20% of the sample of prescribers, were responsible for 72% of all the initiations. What this likely translates into is that there's a small group of people who are doing the fair amount of the safer supply prescribing, and that there's a much larger group of people who are prescribing for 1 or 2 folks. About 81% of people are in family medicine, and most of them have been in practice and have a pretty substantial base of experience underneath them. Interestingly, because this has been one of the criticisms that's been leveled against safer supply, we found that 78% of all of the of all of the prescribers also prescribed OAT medications, so methadone, buprenorphine, or slow-release oral morphine during the period they were also prescribing safer supply. If we look a little bit at the characteristics of some of the clients in the Safer Supply program, we can find that they're overwhelmingly male, about 60%, and they overwhelmingly live in urban areas. And one of the main differences we found between people who were the clients of infrequent and frequent prescribers was whether or not they had a family physician. When they were coming into the programs, overwhelmingly the people who were the patients of frequent prescribers didn't have a family physician coming in, which likely means they had less access to medical care. We also saw an incredibly high rate of infective complications. This includes things like infective endocarditis, like Andrea was talking about earlier. It seems that a lot of the patients who are getting picked up, at least in the early period by safer supply programs, are folks who had pretty significant comorbidities in terms of they were also 44% or 35%, depending on whether they were patients of infrequent or frequent prescribers, had a previous bout with infective endocarditis. And importantly as well, about 75% of the patients of the frequent prescribers had been on OAT in the previous year, which means these are folks likely who had significant experience with other treatment options before they made it to safer supply. In terms of outcomes, I think it's important to mention as well that when we're looking overall at the patients who were prescribed safer supply, we see that people who are the patients of frequent prescribers are staying on safer supply for longer than the patients of infrequent prescribers, and also that overwhelmingly, to the tune of 70% of all of the patients of frequent prescribers were also being prescribed a long-acting OAT backbone, either methadone, buprenorphine, or slow-release oral morphine. Now, the interesting thing here is that the safer supply prescribers are a little bit different. They tend to prescribe more slow-release oral morphine as the backbone that they're using. That was one of the differences that we found. It's also very important to mention that deaths within safer supply prescribing were incredibly rare, and in the 7 days following discontinuation were really rare. And the reason we looked at this was because we have a lot of studies that show that the period after people go off OAT medications is an incredibly dangerous period for overdose. And so we wanted to take a look if that was happening as well for safer supply patients. So now I just want to take a step back for a second. That was Ontario data, and that was before COVID. And I want to look at what was happening in Canada in the same time period. And this was an environmental scan of safer supply programs in Canada that was meant to run up until March 2020. And here they looked at 3 different types of programs. They were looking at injectable OAT programs, so where people were prescribed either heroin or hydromorphone as an injectable for supervised administration in a clinical setting, whether they were getting supervised tablet injection or TOAT programs, or safer supply programs where people were getting access to a take-home prescription of medications. And then we were supposed to stop this study in March 2020, but COVID hit. So we actually went ahead, we pushed it forward a little bit because we knew that there was a lot of new prescribers who were taking up safer supply prescribing in the beginning of COVID. So we wanted to see what ended up happening with that. And what we found was that prior to the COVID pandemic, the majority of safer supply programs were in Ontario. There was 15 in Ontario. There was only 2 in BC in the same time period. If we look at March 1st, there was actually then at that point 60 programs, safer supply programs. There was an increase of 258% between March 1st and May 1st of 2020. The majority of that increase was actually in BC. There was 50 new safer supply programs that started in BC in just that 2-month period at the beginning of the pandemic. In Ontario, we already had 15 programs, and there was 2 new ones that started in that period. So what we saw was, and this was the name of the paper, I don't know if you caught it, it was actually a quote from one of the prescribers who said that COVID opened a can of whoop ass. And I think that was really what started. All of a sudden, it was the intersection of the overdose crisis and the COVID pandemic that allowed a lot of prescribers to feel more comfortable to start prescribing. And that's what we saw in this study. Now, a lot of you have probably heard me talk before about the impacts from the evaluation that I did of the London InterCommunity Health Program. I just want to go through them really, really quickly again today because I think that there's a really important message right here that we're not hearing a lot of times. And this is the message about how much these programs are helping people and how much they're saving people's lives. And I think that right now, it's been a period where we haven't been able to meet, we haven't been able to come together. Also, safer supply programs weren't meant to be scaled up during the COVID pandemic. We weren't supposed to be doing this work in the midst of a massive public health crisis. So I just want to pause and acknowledge the huge amount of work that everybody in this room has done to build up and scale up programs in the midst of absolutely an unprecedented circumstance and an unprecedented time. I've been spending a lot of time with programs. I've seen how hard everybody's worked. I've seen how burnt out everyone is. And I think it's really, really important to acknowledge the super hard work that you've all been doing, but also the really positive impacts that it's been having on people. And so these are some of the quotes. This is what some of the people have said to us about what Safer Supply has had, the impact it's had. It's been nothing but good for me. I've got my family, I've been housed for the first time in 10 years, I'm volunteering, I've done things that I just didn't care about, had no motivation to before. I have interests now, things I used to like to do, that I didn't know I liked to do because I never had time to do anything I like to do. I like helping people, and I walk around and I find myself doing that, and having more time to be myself, instead of this guy who hustled and robbed everyone. When we asked people about their use of opioids from the unregulated street supply before they were on Safer Supply and after they got into the program, you can see the really, really high rates of both injected and smoked fentanyl use. We're not talking a lot generally about the impacts of smoked fentanyl use on people, and I know it's been really, really difficult because we lack a lot of options, but we really, really do have to pay attention to that, because what you can see here is that people's injection, their use of unregulated opioids from the street supply by injection drops quite significantly when they start on Safer Supply programs, but they keep smoking fentanyl. And so I think we really, really need to be thinking as we're going forward how we can help meet the needs of this group of folks who are smoking fentanyl. We also saw in the London InterCommunity Health Program evaluation was that 35% of people reported that they were no longer injecting drugs at all. I think it's important to focus on this, but not to focus too hard on this, because while if people are choosing to move in that direction and they're choosing that they don't want to inject anymore, that's a very, very positive thing for them. But I think we've had such stigmatization of injection drug use that we have to be careful not to focus too much on this, because people tend, especially because of the infectious disease transmission risk around HIV, Hep C, there's ways that we can continue to support people who choose to continue injecting their drugs and lower infectious disease risk. But I think that it's important to realize that people have to be able to make this choice for themselves. People told us a lot about one of the main effects of Safer Supply programs was they were able to look after themselves better than they've been able to do before. In fact, in one of the focus groups that I moderated, people were actually talking about how much weight they'd gained, and they were all comparing how much weight they'd gained since they started Safer Supply programs. People's rate of overdose dropped dramatically once they went into Safer Supply programs, and you can see this. This is the difference between the past 6 months and the past month. And involvement in criminal activities dropped dramatically as well, from 86% to 38% among current clients, with 44% of people reporting that they had no involvement in criminal activities at all since starting Safer Supply programs. And here, you can hear this really evocative quote that this person told me about how much the change that it's had on them, not having to engage in criminal activities in order to be able to have to support their drug use. The place where we haven't seen much change is in rates of homelessness and food insecurity. And I think that we really have to pay attention going forward to the effects of the housing affordability crisis on the people that we're working with in Safer Supply programs. This is going to be the massive issue over the next couple of years. And I don't see it getting any better, unfortunately, but I think that we really, really do have to talk about we're not dealing with the dual pandemic of COVID and Safer Supply, or an opioid overdose. We're dealing with the triple pandemic. And the third aspect of this is housing insecurity and homelessness, and the awful, awful impact it has on people. We're going to be really limited in the way that we can help improve people's health if they're living in tents in the winter without access to running water and toilets and heat. And that's just the reality of it. Health services use dropped quite dramatically too, with people telling us that they had less use of the emergency department as well as less hospitalizations. Now, this is all self-reported patient data. So one of the things that we wanted to do is we wanted to go into the health administrative data, so the data that we get every time that an OHIP card gets swiped in Ontario. And we matched Safer Supply clients in London to other London residents who had opioid use disorder or who had an indication of opioid use disorder in their charts with people who were not on Safer Supply. So we wanted to do this comparison of the impacts of Safer Supply prescribing on groups of people in the same geographic area. And we looked at ED visits and hospitalizations, as well as some of their clinical characteristics. This paper has currently been submitted for publication, so I'm giving you a little bit of a preview of the results. But in terms of the main findings, the health administrative data actually matched really closely what London clients were telling us about themselves. We saw dramatic and significant reductions in emergency department visits, inpatient hospitalizations, and hospitalizations for infectious complications among people who were in safer supply programs in London. There was no change whatsoever in the matched controls. So we can see this population level impact of safer supply prescribing. We also saw a decrease in healthcare costs, not including primary care costs. Interestingly, for safer supply clients, their drug costs, their medication costs, they went up quite significantly once they got into safer supply programs. That's not shocking. We're actually starting to prescribe medications to them. What was interesting is that a very small proportion of that was actually due to the opioid medications they were being prescribed. Much of the increase in the medication costs is likely due to treatment for other chronic conditions, as well as initiation of hepatitis C and HIV treatment, which is overall a positive and net benefit, not just for safer supply clients, but for the healthcare system as a whole. And so I think that it's really, really important. This is hopefully going to be out very, very soon, but it does provide some evidence that the voices of people from London, from the program, from clients themselves, were able to find actually that what they were telling us was very much reflected in the health administrative data as well. So thank you all. I'm going to pass over to Carol now, and she's going to tell you a bit more about her research that she's been doing.
Hi, it's my pleasure to be here this morning. I'm here on behalf of a much larger team. So I just want to start by acknowledging the land on which we meet today. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous people from across Turtle Island. And I'm grateful to work on this land, and I'm also a settler. It's not... Okay, Gillian's taller. Yes, thank you. I'd also like to acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this nation home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and consider how we can each in our own way move forward in the spirit of reconciliation and collaboration. So what am I going to talk about? It's the Carolyn and Adrian show, so I'll start and Adrian will finish. I'm going to give you an overview of our project that we're doing in London and several sites in Toronto. I'll tell you a bit of about our analysis and our early findings and some next steps, and then we'll tell you about another project that we're doing. We're going to start in the fall. So our study seeks to understand from the perspective of patients, prescribers, nurses, and allied health providers, and also pharmacists, the experiences of rolling into receiving and staying in safer supply programs. So we're really interested to understand, like, what's it like to be in these programs, right? And what's it like to deliver the programs? We're interested in the relationships between clients and clinicians because they're pivotal. We're also interested to understand the perceived impact of the program on the risk of overdose and other drug-related harms, the impact of safer supply on treatment for HIV and also hepatitis C, the impact of COVID-19 on safer supply practice. That was an objective that we added. Didn't really intend to do that, but we are looking at that. And we're also interested to understand how, if at all, gender and racialized identity influences the experiences of safer supply, which is a more challenging objective for us to answer, I have to say. And we've tried pretty hard. So it's a qualitative study where you're talking to, as I said, people enrolled and people who deliver the programs. We used purposive sampling, so we the staff at the sites helped us so tremendously to do this. So we tried to sample people of varied genders and race ethnicities in the programs, and we tried to talk to every clinician working at the programs. So we were delayed because of COVID, but we eventually convince U of T to let us do something, and so we talked to people over Zoom, telephone, and also in person, which was always the best way to talk to people. And we did team-based thematic analysis, and we also have an amazing advisory group who have provided feedback throughout. A couple of members are in the room today. We've talked to 53 clients in Toronto and London, in person, on Zoom, or on phone. They averaged about 46 years of age. Over half were men, 3/4 were white, and 19% were Indigenous, and the remainder were other race, mixed race, and the like. And just around 13% were HIV positive. And you can see where we've been. We've been to Street Health, Parkdale, Queen West, Parkdale, the Queen Street site, and also the Parkdale site, South Riverdale, and London InterCommunity Health. That should say London InterCommunity Health Centre, so sorry about that. We've also talked to 21 service providers, most of them women, most of them white, and of varied ages. We've talked to case managers, outreach workers, health systems, navigators, client care supports, community health workers, physicians, nurses, and nurse practitioners. And we're missing pharmacists, but we've also, I think we had 13 pharmacists? I don't remember. We talked to pharmacists as well. And so what are we finding? One of the things, the striking things that we heard when we were doing the interviews was this, and several people spoke about this sea of need that they were up against as providers. That criteria were developed and articulated for who could get into the programs, and focused on those most at risk of what were considered negative outcomes. So a history of unsuccessful opioid agonist treatment, that's often called refractory in clinical terms. Frequent opioid overdose, identify as women, LGBTQ2S, BIPOC, engaged in sex work and living with unmanaged HIV or hepatitis C and or palliative. So that would seem at the surface to be like fairly robust criteria that would restrict to some extent some access. So we talked to a big program, and we talked to newer, smaller programs. And for the smaller programs, they struggled to keep up with demand. There was also the pandemic happening, and they had to make decisions about who was going to get in and who wasn't, because there were only so many people that they could see and provide appropriate care to. And they really struggled to figure out how to do that and how to feel good about the decisions that they were making. So the different programs, they worked together, but they also had slightly different, not slightly, they had different populations as well, even though in Toronto they're all close together, but they, different pockets and different sets of needs across the city. So they adapted over time to try and address this, which was actually to slow the enrollment, because they only had so much staffing. So they opened and closed wait lists. Some reverted to same-day enrollments instead of to deal with no-shows. So they, wait for somebody, and then they wouldn't show up, and then they wouldn't actually be able to enroll someone that day. So they went to same-day enrollments. They reduced times accepting referrals, so they stopped accepting referrals. They did phone intakes and in-person. That was partly related to COVID, to speed up the process, but also to speed up the process. And also they restricted eligibility increasingly to more and more complex clients with complex mental health and physical health problems, and who were housing insecure. And so that slowed the admissions, right? But it also, for those programs, increased pressure on severely stretched resources already. So their clients that had increasingly complex needs required more of their attention, and led many to question, what are we doing, and why can't we have more resources, right, to get this done, and what can we do with what we have? And as it says at the bottom of the slide, it created a lot of frustration, a lot of concern, and people were deeply upset about their capacity to address this, what they call the sea of need. So that's a bit of a downer slide, but the next slide is less of a downer. It's, they also spoke to us a lot about the transformative nature of their care, and that, prioritizing people with a history of overdose, HIV, women, 2S, LGBTQ, and BIPOC, really was transforming their lives, right, for those patients. So what that also meant is, so as one of them said, I know for a fact because my patients tell me every day this is a life-changing and a life-saving intervention. And Gillian presented almost the exact same quote, right, from someone else. There's nothing else we do in primary care that consistently gets that response, right? Despite, feeling really overwhelmed, they were also seeing that what they were doing was making a difference. We have also heard a lot about how Safer Supply is bringing in people who have untreated HIV and hepatitis C, which you all know because you do this kind of work. So clients that were previously undiagnosed or had unmanaged HIV are being referred to the program, so addressing that eligibility criteria. And so one person said, so almost every intake I do, an individual is hep C positive, if not HIV. And then another person said, so we've probably had at least 5 from the hospital team that had CD4s of 0 and were imminently going to die. So the docs reached out to us. So the programs are taking in those that really most at risk. So there's a big question about, like, what's the outcome to measure for Safe Supply? What shows success, right? Because it's not like for other like addiction kinds of programs where you're looking for, reduced use, right? And so providers, we ask them, like, how do you know that you've been successful? So providers talk to us about that Safe Supply should be, one of the measures should be on successful engagement of people living with HIV and hepatitis C. And how programs should also measure increased access to harm reduction supplies and reduced engagement in sex work and improved testing and treatment engagement in care. Another important thing that we hear a lot about is the impact of related to who's coming into the programs, but also once people get enrolled and they get stabilized and they get a lot of their care, their needs met, that there's improvements in the HIV and hepatitis C care cascades, right? So it's not only just finding more people that have HIV, but it's also about, improving their outcomes, setting them up with HIV or hepatitis C treatments and the like. And people also talk to us about the need to be more reflective about what those cascades look like for people who use drugs, because they're not, the existing measures don't really address the needs of people who use drugs per se and or on Safe Supply, so more work needs to be done in that regard. So we also heard about the challenge of keeping up with the unregulated supply of drugs, because as you know, that's ever changing and the tolerance levels are ever increasing. And a lot of the prescribers talked to us about, like, the deep concerns and worries they had about what they were doing, how they were doing it, and how they were going to manage this for their patients. And also talked about, when some of the drugs were unavailable for a while, what they did during that, and the implications for their patients, and also for their practices, like what this was going to look like, right? Because, as Dr. Sereda was talking about at the beginning, this isn't the favorite practice of a lot of colleagues in the medical community. So that's a big issue of, a challenge of keeping up with the unregulated market. So that's a little bit of a tour through what we're hearing from service providers. We have lots more data. We've just, we're at the point where we're actually going to have more detailed analyses, but we're going to focus on things like, what's a patient-centered care model or trauma-informed practice that you have, developed, and try and, describe that in a comprehensive way, the impact of COVID and the like. And I will turn you over to Adrian now.
Can you hear me? Okay, let me know if you can't. I'm a mumbler. Thank you. Thank you for this invitation. I sort of imagined I'd be behind like a solid podium so you couldn't see that I'm wearing shorts and dressed like a little boy. This is like the first time I've left my house in like 2.5 years, so I'm feeling, thank you. I'm feeling a bit overwhelmed, but also in a good way. Seeing everybody here, seeing some folks that I haven't seen since 2019. I came to Toronto for a meeting at the Dalla, Lana, and I got pulled into something else, something I had not heard about, a discussion of safe supply on the first floor. This was like July, like 2019, and yeah, I had never heard of this, and I just thought, this is amazing, and I want to be part of this in some way if I can. And it was the first time I heard Andrea talk and Nanki, and I just thought, yes, this absolutely makes sense to me, and it's amazing to see how far this community of practitioners has come in this time, in this incredibly challenging period, and yeah, I'm just overwhelmed, and yeah, thank you. So I'm going to talk about the client interviews, the perspectives of people who use drugs, who are on safe supply. We're a bit early in our analysis, and there's no way I can kind of give justice to the richness of these 53 interviews, folks who sat down with us, some over Zoom, but also some in person. I had the privilege of doing some of those, sitting with a stranger who's masked, and yet being so committed to the program and wanting people to know how much they had benefited from it. And so we talked, and they were very powerful interviews, ones I continue to think about and reflect on. And so this is very, very preliminary, and please feel free to ask sort of any and all questions. You know, this is just sort of a very sort of first stab. And I can tell you what you already know in terms of clients reporting very positive health outcomes, improvements, mental health, obviously, overdose reduction. But for me, the big takeaway was really around kind of care, meaningful care and engagement and support and community. And I'll cover some of that. So in terms of the benefits, often before we even started the interview, the moment we met, someone would share, I just want you to know how this has changed my life, that this is keeping me alive. They helped me with everything here. And it was just so powerful to hear. A recognition from clients who knew that, you know, they're members in my community, maybe even intimate partners who are not enrolled, and I know that they're struggling. I know that we're losing people in our community. You know, folks saying that, again, like, you know, I think I would probably be dead by now without this, and hearing that over and over and over again. And the sense of like, there's nothing negative. I can't say anything negative. Everybody here is just so wonderful. And we were interested in talking about kind of the intake process and titration. A lot of the clients we talked to kind of said that was a very difficult period for me in my life. Maybe I was in crisis. It was kind of like peak use, and they didn't necessarily kind of remember the intricacies of that. They generally said it was okay, like the process was okay. Of course, there were challenges with kind of remembering you know, like all of the questions they were asked, but generally, you know, they didn't find it invasive. They really felt like finally someone was listening to them. And of course, there were challenges with kind of dose like matching, and as this one participant said, like essentially, you know, the fentanyl that I'm getting on the street doesn't have like proper like dosing, right? I don't know exactly what I'm getting. And so having to do that work, having to negotiate with a prescriber But the general sense being like, I get it, I get that they're constrained and we have to kind of figure this out together, you know, and it might take a little while. We heard a lot about client-directed care and monitoring. So going from the prescription as kind of the, you know, the basic piece to maybe working up to kind of wraparound care. And that we heard from folks who sometimes had been you know, prevented for many reasons from receiving client-centered healthcare for years, had very, very negative, traumatic experiences with healthcare providers, you know, who said, I don't trust doctors, I've been abused by doctors, you know, horrible accounts of medical violence, but then saying, I believe that this individual prescriber does care about me, you know, describing you know, different sort of engagement and rapport styles, and you know that you know, this doctor understands what people like me go through, and the thing, you know, that we have trust issues, and this sort of like general kind of like trauma-informed approach where participants said, like, you know, people in my community are really struggling. It kind of manifests in complicated ways, but the team here will work with us. You know, somebody might take me out if I'm having like a really hard time, and stuff like that. And generally, just a lot of appreciation about that and over that. And something I found really interesting is when folks re-engaged with the healthcare system, and Gillian touched on this, they had a lot of unmet needs, sometimes decades worth of unmet needs, and by virtue of, you know, getting older, suddenly having all of these new needs. So, you know, addressing things like, okay, I'm now menopausal and I need support around that in addition to my safe supply. Okay, and the monitoring piece, it was interesting to hear. I think we had something like 80+% of participants had tried methadone at different times in their lives. It didn't work out for them for the reasons that, you know, we're aware of, the surveillance. But they described, you know, like urine screens and stuff in safe supplies very different, as this was part of their health care. This was part of a dialogue. You know, I talked to folks who said, I'm actually really interested in what's gonna come up in the results, and you know, that will then decide if I should go up or down or whatever. So the interviews often started with clients saying, you know, I only do my safe supply and nothing else. I don't touch anything else. But then, you know, as we talked, there was a recognition of kind of the ongoing need sometimes to use, you know, unregulated fentanyl. And, you know, some people felt shame about that, and yet were not responded to with shaming. That, you know, again, it was, okay, well, let's talk about that. Let's talk about your needs. You know, maybe we need to increase your dose. And we did have, you know, some participants who struggled, who were using like 3 grams of fentanyl a day, 5, 7, and it was just very, very difficult for them to transition, right, to Dilaudid. And then we heard some really interesting kind of descriptions of why that might be, of why kind of maybe every few weeks somebody might get pulled back. You know, this participant kind of discusses a recognition of like the amount of benzos in the supply in their community, and that they sort of kept getting pulled back in as they were then dealing with opioid withdrawal and benzo withdrawal at the same time, and that's sort of the unique situation that creates. Of course, we heard about the social determinants of health, improved access to housing, income, food, education, and just some like remarkable stories of, you know, I'm so happy, I've gone back to school, I'm able to pursue things that I never thought I'd be able to. So, you know, again, I was able to maintain stable housing for about 1.5 years. I was homeless before, but now I've had an apartment for 2 years. And just an incredible sense of pride, sitting down with somebody and asking them, well, tell me about your new apartment. And that this was a goal that they had set for themselves and that they were able to achieve with, Safe Supply as the foundation. And getting to eat, right? And not worrying about it, and and having money left, to buy food. Okay. And so for me, and this is one I think about a lot, is the reconnecting. And reconnecting with friends and family and community. So we kind of came in with this idea of, well, tell me about how you negotiated your dose with your prescriber. What was that like for you? And people really, really wanted to talk about their friends and family and being part of a community again. Reduced crime and victimization. We didn't go in with the intention of asking about that, but so many participants wanted us to know that Safe Supply sort of enables them to not engage in criminalized activities, and also sort of reduces their exposure to certain kinds of victimization. And sort of these wonderful conversations about becoming maybe somebody new, identifying in new ways, and imagining a future self. And I don't know if you saw in the previous slide, there was mentions of like going on vacation. And again, these goals that some of us, of course, take for granted. And I'll just read you this quote. So, well, like I said before, I don't break the law now. I'm staying out of jail. It's really helped me with that. I'm starting to have a little bit of relationship with my children, which I haven't had any relationship with most of their lives. And that's been good too, because I'm more of a person that can be trusted. And their mother's, more trusting of me now because I'm not going to jail and I'm not doing these things. And there's a lot of talk about children, about, the pride that, I'm thinking about some men that I interviewed, and to be able to say, like, my kid can visit me now and can stay with me. And it was just very powerful. And I feel wonderful because I don't have to do crime anymore. And people are telling me the same, like, are you the same person? Like, did somebody crawl inside you? Because I'm not the same person, and I'm not. And this program saved my life. And I'm talking to my family again. Like, I can't complain at all. And just this very sweet one with this gentleman I spoke to who now goes on long walks with his partner and is enjoying boredom. And he's just sort of, happy with that, and the lovely introspective conversations that they can have. So, I mean, in terms of thinking about how we define success with Safe Supply, I appreciate that in the kind of hierarchy of these things, that these may not be seen as the most important to folks in government, but I think this is tremendous. So just want to highlight our colleagues. Gillian is also, of course, on this team. And then, Carol, did you want to talk about the Hamilton?
Sure. Sure. So I'll bring that down. One of the findings that we're going to follow up on is discussion of safer supply. I don't really think it's versus methadone per se, the conversation, right? But sometimes it's pitched that way. So we got some money to do a new study in Hamilton where we're going to look at safe supply prescribers, people who are prescribing methadone and buprenorphine. And I don't, people are telling us different things, that there are two camps, but other people are telling us it's not exactly two camps in Hamilton. With the prescribers, we're also going to talk to people who are in the programs both a safe supply and methadone and buprenorphine, and those who are not. We're interested in two particular things: how the COVID-19 pandemic and also how the fentanyl are changing addictions medicine. Like I gave you a bit of a slice of that when talking about, you know, the impact of fentanyl on the prescribing practices. So we're going to take a deeper dive on that. So what's it like if you're in those programs, you know, and if your tolerance has changed, and also what's going on with you if you're not in those programs and what it's like. We're going to have a conversation with the prescribers about their practices and how they feel about different medications and the prescribing of them. So that will start sometime in the fall. And I think we are back to Nancy. So thank you.
So we have about 15 minutes for questions. There is a mic in the middle of the room, unless you are a speaker that can project really well. But does anyone have any questions for the panel? And first, thank you. Thank you all. That was great.
I just wanted to introduce myself. My name is Joseph Rudniski. I'm part of the Safer Supply team in Peterborough. And I just wanted to say to everybody that spoke today, Rebecca, Dr. Carol Strike, Adrian, Guta, Gillian, Kolla, and just everybody that had a part in saying something, and especially my two heroes, Nancy Henderson and Carolyn King. They welcomed me to Safer Supply off the streets, and if it wasn't for them, I don't even know if I would be here today. They're my fucking heroes, and all of you guys nailed it today. Thank you.
Thanks, everyone. My question is around, are there ways that you're going to be able to talk to people that maybe started Safe Supply but didn't continue in it, or people who aren't a part of the group of like engaged, this is awesome and I'm loving it? Because I know for sure, at least in Hamilton, probably everywhere, we've got folks who maybe come and do the intake and we don't see them again or aren't continuing on.
So yes, so we'll have people who are in treatment. We don't usually use that with Safe Supply, but like in a program, on a wait list or not. And that's interesting that you raised those that aren't or didn't stay, right? Because when we ask the programs about dropouts, they don't really have a lot of dropouts. So we've tried to talk to people who have dropped out, but they're hard to find, to be perfectly honest. And that also, I think, tells us a little bit about how those programs operate, right? The Safe Supply, because they operate different than, at least my understanding. I haven't studied methadone programs. I don't do methadone, like, you know, for a long, like I'm not a methadone prescriber, but where they have stricter rules. So we don't see you like 2-3 times and see you later, alligator, right? And that's not the case with the Safer Supply programs that we've spoken to. So there's like a profoundly different philosophy applied. So we will talk to you about trying to find those people, for sure. Thanks, Claire.
And I think that we can find, in using some of the health admin data analyses that we're doing, we can see people who started programs and then didn't continue on the programs. And Carol's right, there's not very many of them. In fact, even in the slide that I presented on the Ontario data about retention and treatment, most of that ended because we ended at March 31st, 2020. We just like ended the look back period. And most of those people were actually still enrolled at the end of the look back period. So it did seem that the programs were retaining people to a pretty high extent. I will say when I was doing the London evaluation, I did focus groups with people who were on the Safer Supply program, and then I also did focus groups with people who were on the wait lists for the Safer Supply program. And those focus groups with folks on the wait list were some of the hardest I've ever done in my life. People were it was really, really hard because folks just like saw this and saw getting into a program as something that could really, really change things for them. They saw people in their community who'd gotten on the programs and how much it had changed things for them. And the level of need, and I love the way that Carolyn and Adrian are describing it in terms of a sea of need. When you talk to folks who really, really want to get in, you see that so strongly. And it was absolutely heartbreaking to sit there with folks and hold space with them around that. And I think that that's an important part to highlight because the capacity issues are leading to a real level of moral distress among folks who are working in programs, and particularly the folks who have to do this triaging into the programs, right? It's hard work on a daily basis to engage in. And I just want to acknowledge that's like one of the prices that comes with the really small pilot nature of these programs and the rollout that's happening. And among all the other forms of moral distress that people are feeling, and that's really a big one too.
I'll just add one more thing to my answer. So it's not only that people don't get discharged from the programs that we heard about, it's the level of effort that we would hear about from the nurses and some of the other allied health of finding their clients, right? Like, I've never heard of that before. They'd go looking for their clients, and they would like really, really work hard. And they would also work really hard to address their needs, right? Like, if you're struggling, like, what else can we do, right? So, yeah. Anyway, I'll end there. Sorry.
Hi. Thanks so much for all the work that you do. The research is so valuable to the work that we do on the front line, so I wanted to say thank you for that. And I just wondered if you could speak a little bit to, I'm struggling as an old school harm reduction worker trying to work within this medicalized model of safe supply. And I think about Vicki Roberts' model of ethical pain is what causes the damage for us in this work. And I'm trying to sort of be okay with it from an evolutionary point of view, like I'm working towards changing a model. But it's so exclusionary for stimulant users. It's so exclusionary for benzo users. And you know, our harm reduction kits we don't even have anything that we offer for weed users in harm reduction right now. And so I'm struggling around the idea that we have sort of moved ahead on opiate safe supply, but we're stuck everywhere else, and how to continue to do this work ethically without pain for the people that I'm not able to include. And I just wondered if you could speak to that a bit.
Thank you so much for raising that, because I think it's a really, really important point. I think that the issue of medicalization, and I don't want to preempt some of the other discussions that are going to come later in the day, but I think the issue of medicalization is really the crux of the matter going forward, right? I've done some work in medicalization of harm reduction generally, and I mean, I always talk about how all of our best ideas in public health with people who use substances are because we stole them from people who use drugs in the first place, right? So needle and syringe exchange, people who use drugs were doing that with each other to prevent hepatitis B transmission, and then public health stole it when it was necessary to address HIV. We did the same thing with supervised consumption sites, right? People were always watching each other's back. People were always helping each other out in the community. And then when it was necessary for public health to deal with some of the public disorder, then we stole that from people who use drugs as well. We medicalized it, we public healthized it. People who use drugs have always been coming together to buy drugs together, right? And so I think that this is really the major question about how do we medicalize something but not lose the sense and the voices, and how we can center the real strong concerns that people who use drugs have about this. And I'll be honest, like most of people who were writing SUAP applications pre-COVID for safer supply programs put in place that they were going to have really strong community advisory boards. They were going to have all of these methods for integrating people who use drugs. And we couldn't do that during COVID, right? It became really, really hard. And so I'm hoping that now, even though we're pretending that COVID is going away, even though it's not actually going away, it's just going to collapse our healthcare system. But I'm hoping that as we move forward, we might be able to actually think about how do we actually pull the voices of people who use drugs back into the programs, right? Because we all know that Zoom does not work for connecting with and ensuring that the folks that we're most trying to reach and we're most trying to be responsive to, it's not a good way to engage with them. And so I think that one of the main ways we do that going forward is that we really, really step back and focus on how we can really engage folks into the programs in a really meaningful and authentic way. I think the other thing is we have to keep pushing forward. I don't think there's anybody in this room who thinks that medicalized safer supply is the end goal or that it's going to be what is going to have a meaningful effect here, right? And just because our governments are going to drag their heels and have to be dragged kicking and screaming into caring about people who use drugs in their lives doesn't mean that we can't continue to push forward and innovate. Because you're right, we need stimulant safer supply. We need to figure out how we're going to deal with benzos, right? Because the combination of the benzos in the dope right now is really, really rough for people. And even more importantly, we need to be dealing with the number of people who are smoking their drugs, right? And in harm reduction, we've generally done an awful job. Like, I always tell people, we didn't have funding for people who use drugs and healthcare services for them in the province of Ontario. We never had funding outside of HIV or Hep C budgets until 2019, right? All of our programming was around this idea that we have to prevent the transmission of bloodborne diseases. And so we've been so limited in what we can do. We've never addressed crack smoking in our community. We've never done, people have done small work to engage with them, but it's always been almost an afterthought, especially when we're thinking about the big public health level. And so I think we do need to refocus on how we can engage with folks who choose to smoke their drugs, because especially with fentanyl, that's a really, really large proportion. We're also ignoring the ways in which people are using drugs together at our own peril, right? Crystal meth, I think, is the elephant in the room all the time, and how we support and help folks who are using a lot of crystal meth, I think, is a really, really current concern. And I do think we have to recenter that and figure out how we can work together on all of these things at the same time.
Thank you. If I can just add to that, I think quite a few of the prescribers also talked about this and acknowledged the very, very limited toolbox that they had to work with. And I think there is probably some innovation happening, which I'd love to hear about. And so certainly, benzo prescribing as well, and a desire to enhance that toolbox. But as well, we heard from a number of prescribers who said, I don't want to be a gatekeeper to this. I want this to be in community hands, community control, and maybe I can just come in and do the healthcare piece, and I will respect however a community wants to do safe supply. And so obviously we need decrim and legalization and a whole bunch of other pieces there as well. But I think it was also part of this conversation. Yeah, thanks.
So we are at 11 o'clock, and it is time for us to have a little break before the fair session. Thank you, everyone. Thank you.